Sir is a consultant medical oncologist at Narayana Hospital. So, sir will be our speaker for today. Sir will enlighten us about the MHSPC and the role of darolutamide. So, sir, now the dais is yours. Kindly initiate. So, shall I share the slides from my side?
I'm sharing. I'm sharing.
Okay, sir. Okay, sir. Okay. Thank you, sir.
Just give me a minute.
No problem.
My slides are visible, no?
Absolutely visible, sir.
Just one. Good evening, all of you. And I would thank for all of you joining after your busy schedule. And I would thank Bayer for this opportunity to share few of the data points on the Aranode study, breaking barriers in metastatic hormone sensitive prostate cancer. Uh, the doublets. Okay, in those patients who cannot tolerate a triplet, in those patients when we give a doublet. So what is the data of darolutamide? So plus ADT, no, that is ARA node study. So we have ARA miss, have ARA node, we have ARA sense, and then we have ARA safe. These are the studies we have. This is the slide. These are my disclaimers. And this is the different standard of care in hormone sensitive prostate cancer has evolved to combine ADT with AR. You know, you started from charted where you said the docetaxel with ADT is better than ADT. And then you have latitude, their abiraterone plus ADT did better. And then you have arches where enzalutamide plus ADT did better. That was in 2009. Then you have the enzamet step, where enzalutamide plus ADT did better. Of course, with docetaxel didn't. Then you have the piece one era of triplets, where triplets did better. Then you have the Harasense data, and then you also have Haranote, and then you have Harasec. So these are some different data points that we have. And today we will focus on the recent Haranote study for doublet of ADT plus Peloton. So despite the treatment with ARPI plus ADT or docetaxel plus ADT, a large proportion of patients with MHSPC will progress to MCRPC within 3 months. What is the unmet need? An unmet medical need remains for an efficacious treatment that offers uh, a differentiated and improved safety profile for patients with MHSPC without adding significant toxicities and with the low drug-drug interaction. Okay, one is safety, and another one is the low drug-drug interaction, So this becomes right. Then, so Arasens is a phase 3 study in combination with docetaxel. It already showed a statistically significant radiological PFS, PSA PFS, time to castrate resistance, and also uh, overall survival benefit. The high risk, high volume metastatic HSPC. And then you have darolutamide in combination with ADT, which provide efficacy benefit with a safety profile in MHSPC patients as demonstrated in the ARANOTE trial with significant Indian patients. So remember, a good amount of Indian patients were there in this study. And then with the ARANOTE data, darolutamide has potential to change the treatment paradigm, as now it would be the only ARPI which could be used with and without chemo. Okay, it's the only ARPI where you can use with and without. So for triplet, the evidence is only with uh, darolutamide. Now, so darolutamide plus ADT plus chemo is already a standard. Arasens proved uh, it is effective and it is safe. ARANOTE was designed to see if darolutamide plus ADT also works well. So, if you see the ARANOTE study design, it was a phase 3 study of 669 patients with metastatic hormone sensitive prostate cancer, 2:1 randomization, darolutamide 600 twice daily with ADT versus placebo plus ADT. So it was a placebo controlled 2:1 randomized study. The main goal was a radiographic progression free survival. That is, uh, the other endpoints were overall survival, time to aggressive or next subsequent therapy, PSA control, pain, quality of life, safety. So after the main analysis, all patients could switch to open label darolutamide. Remember, there was a 100% crossover that could happen. So that's the rationale of the study. Now, who were there in this trial? Patients were similar in both groups with an average age of around 70 years. Many Asian patients, mostly high volume, high glycemic and newly diagnosed metastatic cancer, and they were all balanced. What you can notice, the Indian contribution was significant, and you have mainly de novo metastatic, and around 20% were like recurrent. This is the, and remember, visceral disease was also there in good number. So visceral disease was there in 11% and no visceral disease in a 8. And now let's see the global and Indian participation. So what you can note here is ARANOTE included many patients from Asia, including India, 61 in the darolutamide arm and 32 in the placebo arm. Good representation from India and other Asian countries compared with older trials. See this number. Good representation from India, 61 and 30. And then This is the main result, that is the radiologic PFS. Darolutamide plus ADT reduced the risk of progression, that is the radiological progression or death, by 46%. That is hazard ratio is 0.54. At 1 year, 70% of Daro patients were progression free and around 50% on placebo. So the median RPFS was not reached with Daro versus 25 months with placebo. So that shows a statistically significant 46% reduction in radiological progression or death. This is the subgroup analysis. So the benefit was seen in almost every group, young or old, high or low PSA, high or low volume, different races, with or without visceral disease. In low volume disease, you see the hazard ratio. It is 0.3 hazard ratio. So what I would strongly suggest is, if you have a bone only disease and a low volume disease and you want an excellent quality of life, go for Aranote. If someone has a high risk for a high volume disease, there you go for Arasense. Okay. Now let's focus on some secondary endpoints. Darolutamide showed benefit on every secondary endpoint. Time to CRPC, time to PSA rising, time to needing next treatment, time to pain getting worse. Overall, data is still mature and too early to see clear difference. But what you can notice, time to CRPC, PSA progression, subsequent therapy or pain progression, all are significantly better with the darolutamide plus ADT combination. Now let's look into time to CRPC and pain. So you can see a strong delay in becoming castrate resistant and pain progression. Hazard ratio is 0.4 and hazard ratio is 0.72. Right? Pain delay is especially important for patients and had not been clearly shown with other similar drugs before. So a very valid point. Then let's come to the PSA response. 63% of patients and Daro reached a very low PSA versus 18.5. So time to PSA rising was also much longer, 69% reduction in the risk. That shows how efficacious these drugs are. Now, let's see the PSA by disease volume. Both high volume and low volume patients had higher rates of deeper PSA responses with darolutamide. At every time point, either you see it 1 year, is 24 weeks, 6 months, or 36 weeks, or 48 weeks. You can see the PSA response. So a higher proportion of patients achieved a PSA response, both in the high volume and also in the low volume disease. Then let's go to the subsequent life prolonging anti-cancer therapy. What treatments patient got later? Fewer patients and Daro needed next life prolonging drugs. When they did, common choices were docetaxel or abiraterone, right? So you see the docetaxel, abiraterone, that was the most. Then The incidence of adverse events. Overall safety, the side effects were almost identical between the two groups. Importantly, fewer side effects stopped darolutamide because of the side effects, 6% versus 9%. Placebo had to stop early, and the treatment lasted longer than darolutamide. I mean, longer with darolutamide, 24 versus 17 months. So, in spite of having a longer time of treatment, uh, the side effect requiring treatment stoppage was 6 versus 9%. Okay. What are the common side effects? Most common side effects are anemia, joint pain, UTI, back pain, liver enzymes. It occurred at almost similar rates in both the arms. Fatigue was actually a bit lower with darolutamide. You can see the fatigue that was better with darolutamide. The rest all others, they were all comparable. Okay. So, what are the side effects typical of AR blockers? That is important. Hypertension, hot flushes, diabetes, heart issues, fatigue, rash, fractures, falls, uh, etc. It occurred at similar rates with darolutamide versus placebo. No increase in the usual AR blocker toxicities were seen. And then quality of life. So the fact P, darolutamide delayed worsening of overall quality of life by 5.1 months. It is the first AR inhibitor to clearly delay both pain progression and overall well-being decline. That's the importance. Then the quality of life details, if you see, benefit is seen especially in social family well-being, functional well-being, and urinary symptoms. Other domains also favor darolutamide. So, to conclude, darolutamide plus ADT clearly improved radiological progression-free survival and other important outcomes. Deep PSA responses, first androgen receptor inhibitor to delay pain and overall well-being decline. It has a very good safety profile, and darolutamide plus ADT without chemo, that is the ARA node study, should become an additional standard option for metastatic hormone sensitive prostate cancer. So, I think that's the importance. So, we had NMCRPC where ARA-MIS showed very important benefit. Uh, Metastasis-free survival was, and radiological PFS was better. And then ARA Sense was groundbreaking. Triplet. We previously had triplets that failed, and then ARA Sense was a very clean trial that showed overall survival benefit. And we had a challenge of tolerance in patients with doublet. Abiraterone had issues of hepatotoxicity, blood sugar, edema, hypokalemia, hypertension, diabetes because of steroids. And then we had a challenge of reduced seizure threshold, sleeplessness, these issues. And apalutamide caused rash as a problem, was not tolerable. And you have darolutamide with no significant drug-drug interaction, safe, doesn't cross blood-brain barrier, and it is very effective with improvement in radiological PFS. And the trial showed very valid endpoint improvement. Valid endpoints like radiological PFS, time to pain progression, quality of life improvement, time to aggressive anti-cancer therapy. So ARA note is another very let's say, impressive, attractive option in the MHSPC space. And I would place this in the subset who cannot tolerate docetaxel, who have a low volume disease and a bone predominant disease. So in this subset, ARA note, high risk, high volume, I would prefer ARA-Sense because of a phenomenal improvement in survival. So with this, I would thank all of you for your patient hearing, and I would thank Arnab and Bayer for wonderful opportunity.
Thank you, sir, for your wonderful presentation. And now I would like to ask our panelists if there is any questions. So, sir, we are waiting for 1 minute. If there is any question, we will take.
No problem.
But I think there is no further question from the panelists as your presentation is like so lucid and very easy to understand all these things. Our junior HCPs and the fellows are also there. So, sir, we would like to just to close this meeting. And in future, sir, we would like your assistance and your support for the further meetings. And thank you, sir.
Thank you so much, Arnab. Thank you.
Thank you, sir. Thank you.
Thanks all of you. Good night.
Good night. And dear, take care. You can conclude the meeting. Good night.